Coming to differential diagnosis of leukoplakia, the lesions which resemble leukoplakia are leukoedema, lichen planus, habitual cheek biting, hyperplastic candidiasis, mucus patches, white spot nevus, hairy leukoplakia, and keratotic lesions. The reticular type of lichen planus resembles leukoplakia. More common seen on buccal mucosa, common in adults, particularly after fourth decade of life. Women are more affected than men. The erosive variety of lichen planus is painful and appears erythematosus, and it is associated with estrus. Hypoplastic candidiasis also resembles leukoplakia. Hypoplastic candidiasis is present as white patch on the oral mucosa and on the lateral sides of the tongue. Etiology is Candida albicans. Immunocompromised patients or those patients who suffer from systemic diseases, signs and symptoms aggravate. Leukoedema appears as diffuse grayish white opacity involving the buccal mucosa and other sites of lining mucosa. Presently, leukoedema is considered as variant of normal mucosa in which there is incomplete shedding of parakeratotic cells. Leukoedema tends to disappear when stretched. It occurs almost exclusively in dark-skinned people, and histopathologically, there is a retained superficial layer of parakeratotic cells. The mucous patches of secondary syphilis resemble leukoplakia. There are multiple painless aphthous ulcers, or those lesions have got whitish lesions. They are seen in oral mucosa and oropharynx, and sometimes seen on lining mucosa also. The mucous patches are sometimes similar to that of oral leukoplakia. The edges are irregular and whitish and are raised. So, the mucous patches of secondary syphilis are distinguished from oral leukoplakia by proper history, proper clinical examination, demonstration of trypanoma by serology. Leukoplakia is important differential diagnosis of leukoplakia. Leukoplakia is seen on borders of the tongue. Histopathology is diagnostic, and immunohistochemistry confirms the presence of Epstein-Barr virus. Oral leukoplakia common seen in immunocompromised patients. It was earlier seen in HIV positive men, and now it is also seen in immunosuppressed patients, particularly those patients which are on transplants, have got primary bone disorders, and those patients which are on corticosteroids. Pseudopathogenic is important in that if there are less Langerhans cells seen on the tongue, the chances of Epstein-Barr virus infection are more. Epstein-Barr virus release apoptosis resulting in epithelial proliferation and hypoplasia. What spontaneous may occur on young age? There is familial history. The clinical aspect is more or less diagnostic. Occasionally, biopsy may be helpful. There is bilateral symmetrical distribution, and history of it being present for a long time without change. Significant is in case of white spot nevus. Keratotic lesions resemble leukoplakia. These include reverse smoking keratosis, tobacco pouch keratosis, alveolar ridge keratosis, or frictional keratosis. There can be multiple etiologies or different etiologies. Many a time, there are also various clinical presentations. A biopsy is indicated for these cases. Lichenoid lesions appear as whitish lesions on left buccal mucosa and tongue. We have to check whether patient is having any dental restorations in form of crown, bridge, or amalgam restoration. Biopsy is indicated if the lesion persists even after removal of these restorations. Thank you.